Hello and welcome, everyone. My name is Russell Campbell. I am the director here at the Office of HIV/AIDS Network Coordination, and we are delighted to have you all join us today. This webinar is co-hosted by the Office of HIV/AIDS Network Coordination, HANC, and SAGE. And this webinar is designed for medical providers and researchers. And today we're going to explore the unique challenges and opportunities in HIV prevention and sexual health for older adults. I think some of you can appreciate that when we talk about HIV prevention, in many cases, older adults are often left out of the conversation, and we really want to dig into that and provide an overview of aging in the U.S., including key demographics, HIV incidence and prevalence among older adults, and look at the specific factors that contribute to HIV vulnerability. And we're going to talk about barriers to HIV prevention at the individual provider as well as systems level. And this webinar is the first of a three-part series, and we're going to present key findings from the HPTN 083 study, focusing on STI robustness, changes in bone mineral density, hypertension, and HIV testing algorithms in older participants. We're also going to talk about the importance of including underrepresented communities, especially Black older women, in HIV prevention efforts in clinical trials to ensure more equitable healthcare outcomes. So following the presenters, we will have an opportunity to answer any questions you have and engage directly with the speakers. So I'm delighted to have this amazing panel of presenters, and we're going to kick off with Dr. Jeffrey Kwong, who is widely respected as an authority in the field of HIV treatment and prevention and has a special interest in the care of older adults. He is the co-medical director for the American Academy of HIV Medicine, HIV and Aging Initiative, and a member of the Association of Nurses and AIDS Care's HIV and Aging Expert Panel. Additionally, he is a clinical ambassador for the Center for Disease Control and Prevention's Let's Stop HIV campaign, part of the National End the Epidemic Initiative. He has served as an educational consultant for various organizations, including the Northeast Caribbean AIDS Education and Training Center and Mount Sinai's Institute for Advanced Medicine. We also have Dr. Rafi Lendovitz, who is professor of medicine and interim chief of the Division of Infectious Diseases at the David Geffen School of Medicine. He also serves as director of the UCLA Center for Clinical AIDS Research and Education. He serves as MPI of the NIAID-funded HIV Prevention Trials Network and also as MPI of the UCLA AIDS Prevention and Treatment Clinical Trials Unit. He is also the director of the UCLA Center for Clinical AIDS Research and Education and co-director of the National Institute of Mental Health funded Center for HIV Identification, Prevention, and Treatment Services. His research is focused on the optimization of the use of antiretroviral medication for both HIV treatment and HIV prevention. Following, we have Terry Wilder, MSW, who manages the HIV Aging Policy Advocacy portfolio at SAGE, where she implements the organization's federal and state HIV aging policy priorities. She has worked in HIV care since 1989, providing social services, directing education programs for clients and medical providers, and advocating for policy change. She is an experienced public speaker who has presented at conferences around the world on a variety of HIV topics. Terry is also an award-winning writer who has published on a variety of HIV-related topics through the body's website, among others. Terry served on the New York Governor's Task Force to End AIDS and the New York Governor's Hepatitis C Elimination Task Force, where she contributed to the development of state plans to end the HIV epidemic and eliminate hepatitis C. She is currently a member of the New York State Department of Health AIDS Advisory Council subcommittee, as well as the Minnesota Council for HIV/AIDS Care and Prevention. Terry has been recognized for her work through the PAWS 100 Celebrating Women edition of PAWS magazine, as well as awards from the New York State DOH AIDS Institute, AIDS Survival Project, and Bridging Access to Care, Inc. She is an adjunct professor at Columbia University, where she teaches a variety of courses, including human sexuality, gender and sexuality, queer theory, and healthcare policy. Following, we have Dr. Dazon Dixon Diallo, who is a recognized visionary and advocate in the struggle for human rights through sexual and reproductive health, rights and justice, and the fight against HIV, STIs, and gender-based violence. Dazan is founder and president of Sister Love, Inc., established in 1989, the first sexual and reproductive justice organization focused on women and HIV in the, excuse me, something just popped up here. My apologies. HIV in the southeastern United States. She is a proud member of In Our Own Voice, National Black Women's Reproductive Justice Agenda Partnership, where she advocates for sexual and reproductive health, rights, and justice in public health and prevention policies and programs. Dazan is a co-chair for the Act Now End AIDS National Coalition. She is a member of several bodies of influence, including the Women at Risk Subcommittee of the HIV Prevention Trials Network, UNFPA Global Advisory Council, the Women's Research Initiative, and a founding member of Sister Song Reproductive Justice Collective. If you could please mute your line, we would appreciate it. Thank you. She has achieved a deep reach with a diverse community of listeners for 30 years as producer and host of a weekly program focused on Black women called Sisters Time Women Speak on WRFG 89.3 FM in Atlanta and WRFG.org. She has been recognized and honored and has received numerous awards over the 40 years she has been working in health justice, women's liberation, and human rights. Dazan continues to learn and lead in the fight for sexual, reproductive, gender, and racial economic justice with authenticity, transparency, and integrity. With that, I will move along and just let you know this is the order of presenters. Transmission. And for those of you who are on the call, we would appreciate it if you would mute your line to minimize disruptions. Thank you so much. With that, Jeffrey, I turn it over to you. Thank you.
Wonderful. Thank you so much, Russell, and good morning or good afternoon to everybody. Thank you so much to the organizers for putting this together, and it is an honor to be part of such distinguished speakers. So I will lead us off today with just a brief presentation, really, I think, to set the foundation and to touch on different areas, which hopefully will spark discussion for some robust dialogue later on at the end of this webinar presentation. So the focus of my presentation, I entitled Aging, HIV Prevention, and Sexual Health. Oops, sorry, here, let me just go back. All right. So of course, this is probably not news to everybody, but just to sort of highlight the significance of where we are in terms of our population and in terms of demographics of the US population as a whole. We know that the number of adults 65 years and older is projected to increase in the coming decades, upward to the magnitudes of almost 47% increase by 2050. So somewhere near 82 million individuals by 2050 will be 65 years or older. And that has significant ramifications and implications for healthcare delivery policies and overall operational systems. But when we think about specifically in the context of HIV and HIV prevention and HIV infections, we know that older adults remain vulnerable to HIV. In fact, we can see just from data, this is from the CDC's STI reporting database, from 2013 to 2023, if we look at other markers for potential HIV acquisition, such as STI infection, we see that rates of primary and secondary syphilis, gonorrhea, and chlamydia continue or have increased over that decade between 2013 and 2023 in the magnitude for syphilis and primary and secondary syphilis, six-fold increase, gonorrhea and chlamydia 3- and 4-fold increases respectively. Similarly, with substance use or drug use, we know that older adults, there is still a prevalence or ongoing use in older adulthood too. Most recent data report showed that about 11% of individuals 50 years or older reported ongoing or continued use of substances such as heroin, methamphetamine, and cocaine. With regards to where we are with HIV and HIV infection in the US, we know that there has been a downward trend. And we know that there's a national and the HIV epidemic, which probably all of you on this call who are attending are very familiar with. And we have made progress. However, if we think about it in the context of the total number of new infections in 2022, still almost 31,800 new infections or new HIV cases identified, which, if you break it down, boils down to about 3 to 4 new infections every hour. So during the context of this webinar, 3 to 4 individuals will have acquired or been diagnosed with HIV just during this short time frame. And so although we are making efforts, we still have a tremendous way to go. And if we look at just specifically, I know this presentation is focused on older adults, and if we look at the data in terms of individuals 55 years and older specifically. You can see here, this is from 2022, the most recent surveillance data. If we look by gender, we see that of those 55 and older, the larger proportion of individuals who are being diagnosed are actually women compared to men overall in terms of those 55 and older. But what is, I think, even more in enlightening or more important to identify is that of those individuals who were diagnosed after 55, about a third of them, or a little bit more than a third of them, were diagnosed at stage 3 or more advanced HIV infection. So although these individuals were diagnosed, that is important, we are not catching them or identifying them early enough, which speaks to some of the issues with regards to our overall testing and our overall efforts at preventing new infections in the US. And so we'll talk a little bit more about testing in a little bit, and I know my colleague Terry on this panel will be sharing some information with you later. But if we look specifically at sort of the different cohorts, this is again from 2022, the most up to 2022, the most recent data. This breaks down HIV incidents per year between 2018 and 2022. And if you look at those individuals 65 years and older, you can see that the trend or the overall bar has not moved. Now, plateau and level infection is good, but it's not getting us to end the epidemic, right? We need to see these numbers go down. And although the numbers in comparison may be relatively low, although the fact that they have not moved really speaks to efforts where we need to focus on or consider focusing on in terms of HIV prevention. We know that there are many barriers to HIV prevention in older adults as well. Well, I've just listed a few of them here, including things such as stigma, lack of knowledge about HIV and STIs and substance use, both from the individual level, but also from the provider level. There's misconceptions about risk. There are physical challenges, issues and concerns about cost or insurance or access, although some of those are changing. And I know Terry will talk about that as well. But one of the biggest barriers, I think, is that providers are not necessarily talking about sex or sexual health with older adults. Now, if we look back at some of the study or the data that has been reported on sex and sexual activity among older adults, there have been numerous studies looking at this. One of the more landmark cases, or one of the more landmark studies, was published by Lindell several years ago. And they did a study looking at sexual activity among those 57 and older. And you can see here from this published report that nearly 3/4 of individuals 57 to 64 reported remaining sexually active. And those 75 to 85, 26% of individuals reported engaging in regular sexual activity. In another study, for those individuals 75 to 85, 54% had reported having sex 2 to 3 times per month, and 23% reported having sex 1 or more times a week among those 75 to 85. So again, people as they age still remain sexually active, and sexual health is as much a part of whole person health, as is mental health, as is physical, as is cardiovascular health. It's important that we recognize and acknowledge that sexual health is something that is important to our patients. In one analysis, they asked individuals, if you had an issue about sexual health, who would you talk to? And the majority of people, older adults in this survey, this was out of the University of Michigan, said that they would want to talk to a healthcare provider about their concerns. In another analysis, they did a survey of people who actually did talk to or have a conversation about sexual health with a healthcare provider. 17% of individuals, 65 to 80%, 65 to 80 years old, said yes, they did have a conversation about sexual health with their medical provider. But the sort of the enlightening part of this was that 60% of those individuals had to initiate the conversations themselves, meaning they had to bring it up to their provider. It wasn't part of the conversation. They had to have the courage, they had to have the knowledge, and they had to feel safe in a situation in which to have these conversations. And if that opportunity is not there, that creates a barrier. If we look more broadly at sort of systems level things or in terms of guidelines or recommendations, we know that there are guidelines and recommendations for HIV testing. Many of them have been updated, including hepatitis B and hepatitis C. HIV guidelines have not been updated since 2006. That is about to change, and I know Terry's going to talk more about that. But if we look at the current guidelines, right, they currently say that individuals 13 to 64 should be screened for HIV as part of routine medical care. However, we know that this is still not happening. And with the barrier of 13 to 64, there seems to be something magical that happens at 65 for some reason, where people don't necessarily need to be screened for HIV. I hopefully have provided some information to the contrary to that before. But even if we look at the fact that we do have guidelines that are in place that providers are supposed to follow, we know in fact that that is still not happening. Right, this is information from the Centers for Disease Control, where 75% of individuals who were considered at in populations where HIV acquisition was more likely, 75% were not offered a test as part of routine care. And that really speaks volumes to the challenges of our healthcare system and our healthcare delivery at the provider level, right? What about prevention and PrEP? If we look at the data specifically at older individuals, and this is uptake in percent of PrEP coverage for those individuals 55 years and older. Here again, about 30% of individuals who could benefit from PrEP who are over 55 are receiving it. This reflects very similar to the sort of the larger demographic of the US overall. And I'm sure if we broke down this data even further, we would see that although it's 30% of individuals 55 years and older are receiving PrEP, there probably are significant differences between gender and race, which are not elucidated in this demographic, but we know in this illustration. But I can tell you that that is probably the truth and something that we need to address even further. Another topic that I think is important to consider, and we as clinicians are in this era of evidence-based medicine. But if we ask and we look back at the evidence, and if we look at some of the important registrational trials around biomedical interventions for pre-exposure prophylaxis, you can see that in terms of the age breakdown and the age cohort, who was included in the study population, we can see that actually individuals over 60 or 65, very few individuals were actually included in that, in the studies, HPTN 083, Rafi, oh, I know he's going to be speaking next, had individuals over 60 years old. So fantastic. But again, I think we need to challenge future researchers and future clinical trials to consider maybe focusing or including this population to a greater extent. Another sort of systems level issue or things that may play into some of the barriers that older adults may experience with regards to HIV prevention is public health messaging and campaigns, right? These are messages, these are images from public health campaigns developed by different agencies or organizations, both statewide, national, and international organizations. And if you look at the images and if you look at the messages, although the verbiage, may be age neutral, but if you look at the imaging, the message and the individuals that are selected in these campaigns do not necessarily reflect somebody who may be in their 60s or 70s. And therefore, if they're not reflected in some of the messaging, they may not necessarily pay attention to the information, which contributes to lack of knowledge, lack of awareness, et cetera. So again, this is an area where I think we need to make some changes or at least have some targeted efforts. So I know I covered a lot of different issues, and my goal here was really to sort of highlight and touch on different aspects that impact HIV prevention in older adults. So some of the key take-home points that I want all of you to know are that healthcare teams caring for older adults need to take into consideration physiologic, psychosocial, cultural aspects of aging. We need to normalize conversations about sexual health and make that a part of routine care. HIV treatment and prevention services are not bound by age, and interventions, research efforts, and policies must be inclusive to take into consideration the needs of older adults. Here are some key resources for you, including the Let's Stop HIV Together and HIV Nexus websites, as well as several other organizations listed here. And with that, I'm going to end and turn it over to the next speaker, and I'll be ready for conversation afterwards. Thank you.
Thank you, Jeffrey. And we will hear from Dr. Lendovitz here in just a moment. So, and thank you we do have a question in the chat that we will hold until the end. So for those of you who are on, welcome. And please place those questions in the chat and we will get to those following the last presenter. Thank you.
Okay, thanks, Jeffrey. And I also want to add my thanks to you all for joining today and to the organizers for putting this great panel together. And I think this is a really critical, important topic. We spent a lot of time in the prevention space talking about making sure we have adequate representation of younger individuals, but I think it's equally important to make sure we have representation in our clinical trials that are supporting evidence to lead to the development of new products from older populations, since I can't agree more that we continue to find evidence that sex does not stop at any particular age, and we want to continue to support healthy and positive sexual activity for all adults. With that, my goal today is to just share a little bit from HPTN 083, which I think many of you know, these are my disclosures, was one of a pair of registrational trials that led to the FDA and also global regulatory approvals for long-acting injectable cabotegravir, which, as I'm sure you all know, is the one FDA-approved injectable PrEP regimen we have at the moment. Of course, there's really exciting data that has been presented over the last 6 months for a novel injectable agent, which is lenacapavir. I'm not going to focus on that today since it doesn't yet have regulatory approvals, although we do anticipate those in 2025. So just to remind people, and I can't thank Jeffrey enough for saving me a little bit of time in presenting some of the demographic breakdown of 083. While yes, it's really exciting that between 2.5% and 3% of the participants enrolled were over the age of 50. We can clearly do better, and I think we need to do better. As Jeffrey also pointed out, the number of people enrolled in these studies over the age of 60 were even smaller. It was like 0.3%. And 084, which was the cisgender women's sister study, if you will, of 083, of course, had an age cap of 45 years. So we don't have any representation above that age. But 083 and 084, the study design as shown here, I'm not going to belabor this, right? It was a double randomized, double blind, double dummy, we call it, which basically means that although there were no participants who received all placebos, placebos in each arm were used. So people received one active and one placebo product to maintain the blinding in the study design. And it was a direct oral injectable comparison to daily oral TDF, FTC. And I think everyone on the call probably knows that the study was stopped early in May of 2020 for superiority of the injectable product compared to the daily oral product for reduction in HIV incidence. This was a population of cisgender men and transgender women, and although the median age was quite low, it was 26, and the interquartile range of the enrollments was 22 to 32. There were,
you know what I mean? Like, I know it's YouTube, so then like
if
you were
people
doing it,
could
right? But it's kind of like,
mute
I feel
your
like
line, thank you, that'd be great. Just over 2.5% were over the age of 50, as Jeffrey mentioned. So I'm going to talk about a couple of issues that are of particular relevance to people over the age of 50. One is loss of bone mineral density. Of course, as we all get older, we're all losing bone mineral density, which puts us at increased risk of fractures, both traumatic and non-traumatic fractures. And we know, of course, that TDF has been associated with increased losses of bone mineral density when compared to TAF FTC, compared to placebo, and in 083 as well. There were salutary changes in DEXA, which is the radiographic mechanism by which we evaluate bone mineral density. In 083 in particular, we did a DEXA sub-study that was at 19 sites to look using sensitive DEXA measurements at changes in bone mineral density as people were exposed to the two PrEP agents over time. And we looked over a 2-year period. And in that DEXA sub-study, I want to point out that 8% of the participants were in the age group that was over 50. You can see the race ethnicity breakdown and the median ages in the two groups that were in the bone mineral density sub-study in that table. And I do want to point out also that there were about 10% of representation of transgender women in that DEXA sub-study as well. These were the primary findings. We presented these in CROI in 2023, and it's currently under review at a major peer-reviewed journal. So we hope to have that out in the not too distant future. And on the left side of the slide, you can see a graph that probably looks pretty familiar because it's very similar to what we saw in the Discover study, which compared daily oral TAF FTC to daily oral TDF FTC. So the green is the cabotegravir exposed individuals, and the blue is the TDF FTC exposed individuals. And you can see, positive or salutary changes in bone mineral density in the cabotegravir exposed individuals, and unfavorable or deleterious changes in bone mineral density over the 2-year period for the TDF FTC exposed individuals. Now, 2 years is not the timeline in which you'd expect to see clinical differences. So we didn't see increased rates of fractures, for example, especially non-traumatic fractures. But again, this is a relatively young population, and the 2-year time horizon is not a time horizon in which you'd expect us to be able to see those differences. So the conclusions that we came to is, so you have someone who is either in an older age group, has lower bone mineral density known to start with, like a diagnosis of osteopenia or osteoporosis, or has a family history of any of those things, you might consider one of these agents that has a better DEXA profile in these clinical trials. So I hope that makes sense to people. The other issue that, of course, is really important for people, particularly over the age of 50, is high blood pressure or hypertension, right? And I think probably everyone on this call knows that there's an ongoing question about whether some anti-HIV antivirals increase the risk of hypertension, and that is independent of any changes in weight that may or may not be associated with those antiviral agents. So because there's a sort of a conflicting literature, particularly with regard to integrase inhibitors as a class of anti-HIV medications, dolutegravir, bictegravir, cabotegravir, all members of that class of drugs, we thought that it was a unique opportunity in 083 and 084 to look at without, in a population of people who do not have HIV, were there differences in the rate of newly diagnosed hypertension in this population? And you know, there's a lot of words on this slide. I apologize, and I'll be happy to share these slides if people want to go back and look at this in more detail. But I do want to just say, of course, 083, as we've already talked about, as a relatively young population. You would be surprised if there were a large number of new diagnoses of high blood pressure in this relatively young population. But what I can tell you we saw in the cabotegravir versus the TDF FTC arm, and I'll orient you primarily to the left side of this slide. You know, you don't need to be a statistician or even a clinical trials expert to see that the two lines showing the cumulative probability of a new diagnosis of hypertension really overlap over time between the two arms. So there was not a difference in new diagnosis of high blood pressure in these CAB-LA exposed compared to TDF FTC exposed individuals. So I think that's really helpful. And so, you know, people with a history of high blood pressure or might be in a group with an increased probability of getting high blood pressure, it does not appear that that needs to be something that we need to worry about in terms of choice of PrEP agent. So I think that's a helpful piece of information. And we did break it down. Unfortunately, we weren't sort of forward and thoughtful enough to break this down further by additional age groups. We did break it down by under 30 and over 30. And you can see in the over 30 group, it does appear like there's a little bit of a split between the groups with an increased cumulative probability in people on CAB compared to TDF FTC, but it did not reach statistical significance. So I wouldn't put a whole lot of interest behind that. Russell already mentioned that I was going to take a minute and talk about STIs and efficacy. And as Jeffrey so nicely pointed out already, we are seeing new diagnosis of all STIs across age groups, including in people over 50. And one thing that I think the group really needs to remember is for every new PrEP agent that we need to separately ask the question, does it maintain its protective efficacy in the context of what we call ulcerative STIs? And ulcerative STIs are the ones that usually present with a genital ulcer because, of course, an ulcer, sort of like a moon crater, it breaks down the protective barrier, the lining of whatever the exposed surface is, and so can increase the risk of HIV acquisition. And so interrogating whether or not a new PrEP agent maintains its efficacy in that context is something that needs to be asked for every PrEP agent. We know the answer that the efficacy is maintained for tenofovir-based oral PrEP. And my colleague, Meredith Clement, presented the results of the 083 analysis at CROI this past year, and it's now been accepted and is online in Clinical Infectious Diseases, the journal, so you can find more data about that there if you're interested in looking at this. What I think was the most interesting thing about the STIs that we saw in 083 is, you know, among the 3,859 participants that were eligible for evaluation in this analysis, we diagnosed at least one STI in about 40% of people and multiple STIs in almost 20% of people. But about 80% of all of the STI diagnoses were just in a quarter of the people. So I think that's really interesting. And the specific STIs are shown in the table on the right. I'm not going to spend a lot of time talking about that. But it really begs the question of who are these people? And if we're able to characterize who this group is that seems to get the majority of the STIs, that might be really important as we think about the use of some of these new biomedical prevention strategies against STIs, right? I mean, you've all heard of doxy-PEP, and people are studying doxy-PrEP, and there are vaccines against gonorrhea and other STIs that are in earlier stages of development. So really getting an understanding of who the people are who seem to be particularly, for whatever reason, susceptible, at risk, exposed to STIs could be really important if you're going to target one of those anti-STI prevention interventions towards a specific population. So keep that in mind. And when you look at the STIs and the risk reduction in the cabotegravir arm compared to the TDF-FTC arm, I'm happy to report that the effect, the relative protective effect of cabotegravir was maintained whether or not there was an STI and across age groups. And I think that's really important because particularly when you look at people over 50, where lubrication in the rectal compartment may be different, much as it is in the vaginal compartment. As people age and sex practices may be different, it's really important to break it down and make sure that there is protective efficacy that is maintained across the agents, particularly when you look at breakdown by age. So here are the preliminary data. What you see here is the HIV incidence rates in the left side when there were no STIs, and on the right side when there were bacterial STIs. And the rates in both arms are higher in the context of STIs, and we know that is going to be true. But what's really important is the relative protection between the two groups is maintained in roughly the same magnitude, whether or not there were STIs. And we did a couple of sensitivity analyses of looking at STI rates in a couple of different ways. Again, I'm happy to talk to people about it if they're curious, but I want to make sure we have enough time for our other presenters. So I'm going to stop there. The last thing I do want to just remind people of is we did present data in Munich that interestingly may be guideline changing. A lot of people are interested, in this RNA testing issue, that there's a viral load recommendation for monitoring for PrEP breakthrough. And that's something that, of course, impacts older individuals in a particular way because older individuals are more prone to anemia. So an increased phlebotomy requirement is a big deal in older individuals. And again, in the interest of time, I'm not going to get into these data, and I'm going to stop just with the statement that we presented data in Munich that I hope will be guideline changing and may lead to a removal of the recommendation for use of RNA or viral load testing for monitoring of PrEP failure, not only for tenofovir-based oral PrEP, but also for long-acting injectable PrEP. And those of you who follow this literature closely know that on December 1st, the IAS USA guidelines dropped. They're in JAMA, first author Raj Gandhi, and they're the first guideline to actually remove the recommendation for RNA testing in the context of both kinds of PrEP monitoring. Again, I've gone a little bit over my time allotment there, so I'm going to stop. And again, when we get to the discussion, happy to answer any questions about that. So thanks very much for listening.
Thank you so much, Ravi. That's an amazing presentation, and I know that there are going to be some questions. I have a couple of questions for you at the end. So please keep the questions going in the chat. We are going to continue. Terry, you are up next.
Great. Thank you so much. So again, I'm Terry Wilder. I work for SAGE, and I'm going to be talking about some HIV prevention policy updates. And I just want to start by saying that, when I've been in different spaces with healthcare providers or scientists, I've heard folks say, well, I'm not a policy person. I don't know anything about this. But I want to say that healthcare providers and scientists are so critical to policy priorities and policy work. You all give me stories from your clinical practice that help inform the work that we do around policy advocacy. You give data to us that helps kind of support our policy priorities. And it's so important that we work together to make changes to improve people's lives. So today I'm going to be talking about two particular policy priorities that are very important as we think about HIV prevention in older people. I'm going to start by just sharing quickly about the organization I work for. So SAGE is the world's oldest, largest organization dedicated to improving the lives of LGBTQ plus elders. We've been around for a very, very long time. We were founded in 1978, and our main headquarters is in New York City. And that's where we provide a lot of our direct services. We also have an office in Miami. But I should mention that SAGE is a national organization, and we do offer supportive services and consumer resources to LGBTQ plus older people and their caregivers. We also advocate for public policy changes. That's the team that I'm on. And we really zone in on, our public policy changes that address the needs of LGBTQ plus elders. And that includes people aging with and vulnerable to HIV. And here's our website in case you're interested. So I have some exciting policy news, and I'm looking forward to sharing these two exciting pieces of information. So the first thing that I want to talk about is a change that happened September 30th of this year around Medicare and PrEP. So looks like my kind of fly up just kind of went across, so I apologize if you can't see the bullet points. So there was a change to Medicare, and basically Medicare now will cover PrEP with zero out-of-pocket cost. And this is for both the FDA-approved oral and injectable PrEP medication. The other thing that has changed is that up to 8 individual counseling sessions, which could be things like an HIV risk assessment, risk reduction conversations, medication adherence, can now happen every 12 months and is covered by Medicare. The other thing that has happened is that Medicare will now cover up to 8 HIV screenings every 12 months, which this is huge because it used to just only cover 1, which doesn't really kind of gel with how PrEP works, where folks need to get an HIV test every 3 months. And I've certainly heard from older people who've said, I can only get 1 HIV test a year, so I'm like scrambling around to go to a federally qualified health center or my free STD clinic in my community to try to find other ways to get HIV testing at low cost. The other thing that it covers under this new change is a hepatitis B screening. So some other important information about this that might be getting a little bit in the weeds, but I think it's really important for folks to know is that the billing for PrEP under Medicare is moving to from Medicare Part. Sorry, I'm getting so many pop-ups. It's distracting me. That it's moving from billing to Medicare Part D to Medicare Part B. And the reason why I'm bringing this up, you may be like, I don't work at a pharmacy. I don't really need to know about billing. Well, what's important is that because of this move, if you have clients that you're working with or friends or family members that are getting their PrEP through Medicare, they really need to make sure that the pharmacy they go to is set up to bill through Medicare Part B, because not all pharmacies are. And I'm sharing this because if they do go to their pharmacy to get their PrEP prescription and they find that their pharmacy cannot bill for Medicare Part B, because maybe they haven't filled out the paperwork, they can call this Medicare number, which is 1-800-MEDICARE, to help find another pharmacy where they can get their PrEP medication filled. We are really encouraging folks who are on Medicare and get their PrEP through Medicare to please call their pharmacy way in advance of their pills running out to make sure that they're already set up to bill Medicare Part B. And if they're not, to please call this 1-800 number so that they can help them find a pharmacy that they can go to, because we certainly don't want people to have a disruption in getting access to their PrEP medication. So the other thing that I want to talk to you about that just happened last week is around the CDC's HIV testing guidelines. So Dr. Kwong mentioned in their part of the presentation that the CDC recommendations for routine screening, particularly for HIV, since 2006 has recommended that people be screened between the ages of 13 to 64. Well, as you can imagine, working for SAGE, where we work to advocate for older people, we have been uncomfortable with an HIV testing screening guideline that says 13 to 64, because we know that folks can certainly acquire HIV after the ages of 64, and that guidelines, while they're not laws, they send a message to clinicians, not only in the United States, but also around the world, because certainly people in other countries look at the CDC's guidelines to guide their practice and inform their practice. So we're kind of exporting our guidelines in a way. So we've been very uncomfortable with this HIV testing guidelines for a very, very long time. And we have been advocating pretty, some might say ferociously, to get the CDC to remove this upper age limit. And this slide has a lot of text on it, but basically our goal has been for years to have the upper age limit removed on the HIV testing guidelines. And the reason why is because, you know, many older adults and their providers may not be thinking that older people are vulnerable to HIV. But we certainly have data to show that certainly people 65 and older are vulnerable to HIV and are being diagnosed, and many times are being diagnosed very late. And so we really wanted this to happen. We've had experts around the country, including Dr. Jeffrey Kwong, come with us to meetings with federal officials to talk about this. We've also had people with lived experience who told about their life of being diagnosed late and being concurrently diagnosed with AIDS after the age of 65. And we also know that people have died because they weren't offered routine HIV testing as people 65 and older, and that's not okay. So, you know, how is removing the upper age limit related to other prevention and care services? Well, if you go to the CDC website, you'll see that they talk about the status neutral approach to HIV prevention. And this approach defines the entry point to care as the time of an HIV test. So if we're not offering everyone an HIV test, people don't have the opportunity to be connected to HIV care if their test comes back positive. And if their test comes back showing that they don't have HIV, they don't have the opportunity to be connected or have conversations around sexual health, have conversations around PrEP or PEP or other harm reduction services. So again, Dr. Kwong already showed this slide in their part of the presentation, but this was my driving kind of message every time I talk to a federal official about removing the upper age limit. This slide terrifies me. People were being concurrently diagnosed with AIDS. And again, some people were diagnosed so late that they died. And so this was something that was always in my mind every time I was talking to anyone about removing the upper age limit. This should not be happening. This statistic that affects people's lives should never be happening. So part of our journey in getting this removed and advocating for it to remove was that we work with the presidential AIDS advisory group called PACHA, and we worked with them to pass a resolution in September 2023 in which they said as a group that they recommended removing the upper age limit of the CDC's HIV testing guidelines. And so this sends a message up to the Secretary of Health and Health and Human Services. So that's a great message that a group of people who've been appointed by the president to think about HIV sent up to back this important policy priority. We also had several senators, Wyden, Casey, Fetterman, Merkley, also sent a letter urging the CDC to up their HIV testing guidelines and specifically to remove the upper age limit on these HIV testing guidelines. So we even had U.S. senators that were very concerned about this and how it was affecting older people in the United States. So guess what happened? Well, last week, the Centers for Disease Control and Prevention released their draft recommendations for HIV screening in clinical settings. And in this draft, the CDC proposes removing the upper age limit for the HIV screenings. So they want to eliminate the upper age limit. So this is a huge policy win for us. And we should be celebrating this because this has taken years to do. So this came out last week, literally like the day before I was about to go to an airplane to go to DC for a meeting at the White House. And we're just thrilled. I mean, I'm almost high from this happening. So the CDC's HIV testing draft guidelines have come out. They came out with a public comment opportunity that is due January 2nd. It's not the most convenient time for this to happen. They've given us 30 days. Here is the link to it. So folks who are on this call today, your healthcare providers, your scientists, your folks from the larger community, here is your opportunity to put in a public comment that yes, we absolutely should remove the upper age limit of the HIV testing guidelines. And if you're a clinician who has a story to share of why this is important in the community that you practice, or you are a scientist that can really back up why this is important, this is our opportunity to give that public comment. And I should tell you that they're looking for quality in the public comments, not necessarily quantity. So we're not going to have kind of a cut and paste kind of call to action. They really want people to give quality input on these guideline draft recommendations. So this is our opportunity. And I should also tell you, don't feel the pressure to write a doctoral dissertation. If you go on the public comment portal now, you can see people have given their input, in 1 or 2 paragraphs. So this is a great opportunity for us to get involved to make sure that when the final recommendations come out, that removing the upper age limit is absolutely there so that we can make sure that people in our community of older people in the United States have the opportunity to get the screenings and the services that they deserve. So I'm going to end on this because I do not want to leave this out. Right now in the United States, there are efforts to cut HIV funding. And so I want to encourage folks to go to this link that NASDAD has set up for us to help save HIV funding, to sign the petition that sends a message to our leaders in Congress calling for them to make sure that there are no cuts to HIV funding, no cuts to HIV prevention dollars that the CDC depends on, and no cuts to our Ryan White programs and all of the other programs around the country that HIV funding is really critical to. So if you're interested in learning more about our advocacy efforts at SAGE, you can join our action squad. There's a little tiny QR code there if you want to take a picture, or you can always email me and we can make sure that you get added to get these updates. So I want to thank you so much for allowing me to share these 2 exciting policy updates that are really going to be really critical to helping older people living with HIV and also folks being able to get connected to care, and all of the older folks in our country getting access to HIV screenings and prevention services. And here's my email in case you want to be in touch. So thanks again for having me today.
Thank you so much, Terry. Appreciate it. All that wonderful information. And last but not least, our final presenter is Dazon. Dazon, the floor is yours.
I think I need to change my background because I can't see me, so that means y'all can't see me. Let's see. Okay, hopefully that's a little better. I apologize, folks. I am actually in the chapel where we have just, next door to the National Cathedral, where we have just had an amazing celebration of life, and thanks for the life of a Cornelius Baker. And so I'm grateful to be here. And I will say that this is one of those times where I can actually say following Terry Wilder is not a great idea if I don't recommend it. And I'm saying that particularly, one, because she's amazing, but also because my job is talking specifically around the question of sexual health and prevention among older women, particularly in the United States, inclusive of cis and trans women. And Terry just gave us the opportunity to end on a great note. I almost wanted to start singing since I'm in the chapel. Ain't it that good news? I don't have that kind of song for you today in talking about women, particularly when it's engaging us older folks and prevention. So here's where I start. It's going to be a little bit more anecdotal and experiential. I'm a Black woman who lives in the South. I travel a lot. I will be 60 years old in March. I have an active sex life, and I'm a little on the pink side. And I like them young, I like them mature, I like them fit, I like them a little rough around the edges, with a big heart and a lot of love for their moms and the women in their lives. And so, you know, I'm a widow, I've been divorced, I've been separated, I've been all of those things. And I consider myself now a person who is an optionist. A friend of mine who is on PrEP once told me, actually, she gave me another term for it. She says that she is ethically non-monogamous. I'm down with her. I'm saying all of this because, and by the way, I don't have any issue with using condoms, mostly because I don't have time for any kind of STIs, including HIV. And I'm different, but I'm not unique. And that's where I want to start this, because even as I got to know my own personal primary care provider, I got to know her better before I started asking her questions specifically about, like, why don't you ask me about my sex life? Why don't you offer me prevention options for HIV and STIs? Maybe you should put a reminder in your chart whenever I come around for my annual to add HIV screening and testing to all of the other lab work that you do. And I am an educated person, not just formally, but also in the HIV space. I am a person who has agency. I'm a person who has information and knowledge. And I still have to fight to be asked, to be included, and to be recognized for the lived experience that I'm working with in terms of remaining HIV negative. So in the context of all of this, when we look at what is different and what is unique about the HIV prevention and sexual health needs of women who are aging and who are over 50, the first thing I want you to remind you is that just as much as we're struggling and working very hard to make sure that in data for transgender women, for transgender men and non-binary people who were assigned female at birth, and are also aging and seeking and needing prevention because of the data, what it tells us, there's still not a lot about what their needs are, how they're being addressed, how they're being included, and actually what the strategy is and what the plan is for that to happen. So I'm saying that with the acknowledgement that there's not a whole lot that I can say on the actual data, and that having the anecdotes, the voices and the stories of those people who have those lived experiences is also critical in this space. So I want to also acknowledge that as we move forward. But there's some roots to why it's challenging in terms of having those conversations. The doctor, when I asked her that, her first reply was, because it's not comfortable, because I have been chastised by older folks when I ask them about their sex lives. So she sort of had a hot stove moment where she's not as likely to go back and continue to asking those questions. And I get it, because the data tells us that for older Black women in particular, which is a large population that we're especially concerned about in terms of access to HIV prevention in the biomedical space, is that there are three working themes when they were talking with and creating some narratives with women over the age of 55. One of those was something called mother's silence. And that really is where your debut, where the information comes from, the fact that most moms of people who are Gen X or Gen Z, Gen X or older, didn't have those conversations, didn't get that information from their mothers or their grandmothers or the aunties in their lives. And second to not only getting very little access to that kind of information, but not sharing the lived experience, not telling your own stories, getting out of the silos of shame around sex and sexual activity, getting around the shame and the guilt of the adult child conversations not happening, and providing misinformation because our mothers didn't necessarily learn that. Are folks not able to hear me? Let me unplug. Changes. I'm gonna let that sit for a second. Is that better?
That's much better. Yes, thank you.
I'm not gonna start over if that's okay. Sorry about that, guys. I was trying to keep there's a reception happening. I was trying to keep the area quiet. So I apologize for that. Bottom line is, if I start with where the roots are in terms of communication and conversation and why it's even hard to have these conversations, especially for those who are older, 60s and up, is one, the lack of information, what's called the mother's silence, not getting that information or getting misinformation or incorrect information from their mothers. The other part is that what's considered a theme of early sex experiences as the unknown. Receiving information like, if a boy touches you, you can get pregnant. If you have sex, you can, not even if you have sex, but if you don't have sex, you'll live longer. All those kinds of things that come from the mothers, from families, from our culture, from our communities. And then there is just no real language for discussing sex in a way that is non-stigmatizing, non-shaming, that's in a supportive as well as a truthful and trustworthy space. So if you compound all of those challenges that are somewhat unique to older women, especially Black women, there are these ongoing challenges that we can talk about that are not showing up necessarily in the HIV prevention space, especially in the science. One is the issue of reproductive health, particularly around aging, perimenopause, menopause, all of the signs, symptoms, and conditions that come along with the hormonal changes that happen as a result of menopause, including vaginal dryness, including an increased risk of reproductive cancers, including putting all the things that are related to menopause in one space, like access to information, like access to ongoing comprehensive health education, including sexual health. A second challenge is the lack of awareness included in messaging. And it's rooted in some old and useless assumptions that are deleterious in some aspects and downright prohibitive in others. For example, older women don't have sex. We know that's a lie, but that is a perception and a bias that many providers continue to work with. Or that they don't want to talk about HIV and AIDS. If you don't know what you don't know, then it's hard to ask questions or to talk about them. So it really is up to the provider. It's up to a community health worker. It's up to anyone who engages at any point when someone is seeking health education, health information, health services, to engage around these questions around sexual health as well as HIV. And there's a disconnect between how we value a sex life, because we think that that's a part of mental health, mental well-being. Honestly, it may be irreverent. I heard a comedian recently talk about how the fact that he wants to decriminalize sex work because he thinks it's a mental health practice. He wants medical, what do we call it? Like we have medical marijuana, he wants medical sex work, or medical, he used the word prostitution. But bottom line being, we understand that we value sex life as a part of quality of life. Well, how do you disconnect that from desexualizing older women, if not even invisibilizing older women, as my dear friend Dr. Dawn Smith used to say, that she thinks that as we get older, we become more invisible, that people don't see us, and therefore, if we're not seen, we can't be served. And then, of course, there's the compounding issues of sexual stigma, HIV, and aging all at the same time, and what that brings about in terms of the challenges of asking questions, seeking services, and then persisting once we engage ourselves. Of course, we've talked about stigma. There's a critical situation of isolation. That isolation comes in the form of less socialization, invisibilization, that caregiving is absent, that we shrink in terms of our numbers of friends, and that because we do want to have sex too, there are risks that we take even when we don't recognize them as risks. There's a lack of routine testing. And thank you so much, Terry, because one of the things I specifically wrote and recovered in a lot of my own data capture for this conversation today is that we need to remove the cap. The age cap in terms of recommending HIV screening and testing. We also have to eliminate risk-based screening and testing. Risk-based interventions are not sufficient, they're not realistic. And as a matter of fact, a lot of that is based on the fact that most women don't think of their sexual health and well-being in the context of risk, but in the context of relationships, in context of aspirations, desires, sexual expression. And there's healthcare provider interactions. For example, healthcare providers being able to engage and understand the changes in relationships that happen. For women who are older, there are increased numbers of shifts in our relationships as we age. Gender-based violence and elder abuse are also still critical, and we know that there's a bi-directional association between violence against women and not only the vulnerability to HIV, but the presence of HIV and the vulnerability to gender-based violence. And so these issues are also critical as we age. And mental health and cognitive function are also critical in terms of understanding the level of engagement around HIV prevention. In the Ebony study, and Ebony is a study that is directly associated with the cabotegravir long-acting injectable for HIV prevention, also known as Apretude, engaging Black women on CAB-LE for PrEP by optimizing novel implementation strategies is what Ebony stands for. And Ebony 4 is actually a post-trial, it's a post-phase 3 study that in this instance was specifically looking at staff study participants. In other words, checking on provider perceptions of appropriateness for using CAB-LE. And there were some interesting details that came out of that study. First and foremost, of the, I can't remember the number specifically of study participants, 66% of them believe that there are specific demographics that should be characteristically applied when screening and recommending CAB-LE. In terms of who is most appropriate in those demographics, men who have sex with men, transgender women, people who are under the age of 35, Black folks, and people who are Hispanic or of the Latinx experience. I didn't hear anything about women in that regard. Understanding that when we talk about a PrEP to need ratio, that Black folks obviously have a much lower ratio, which means they have a higher unmet need for access to PrEP. But there's also a concomitant PrEP to need low score for women. There's a concomitant PrEP to need low score for people who are under 35 and for people who are over 55. In terms of their perceptions of less appropriate opportunity or characteristics and demographics, lesbians, people over 50, heterosexual men, non-binary folks, and white folks. Again, did not hear women, so that means we're somewhere in the middle and have to be captured in some of those other categories. In terms of ranking risk, which also comes in the context of the provider, not necessarily the end user, the behaviors that they rank for risk are partners with HIV, sex without a condom, sex in the last 6 months, sex with people who inject drugs, and anal sex. In order to understand these things, you actually have to ask people. Most providers, unless they're in an infectious disease setting, unless they're already in an STD condition or framework, these questions are not typically asked for women when they present. And there's so many missed opportunities for that. And in terms of the lowest risks for people who should or might be offered CAB-LE, issues of monogamy, oral prep on, they're already on oral prep on demand, which is not an option for women. They're adherent to their daily orals, or they're not adherent to their daily oral prep, or they have requested Apretude on demand or spontaneously. None of those things are specifically happening with women, mostly because we're not informed, we're not engaged, and we're not asked. So by the numbers, these healthcare staff have reported high levels of appropriateness for Black women, and older women in particular, but they've also ranked populations and behaviors traditionally associated with PrEP already as also appropriate for CAB-LA, but they have not done so in their behaviors. And so we need better tools to identify those folks who could best benefit from PrEP, particularly from CAB-LA, and especially when we begin to disaggregate it for the needs that are associated with women. In terms of the latest news, and I think we just saw yesterday, I think it is, that Science Magazine has now determined that Purpose 1 and Purpose 2 studies from Gilead centered around lenacapavir as the twice-a-year injectable for prevention of PrEP through sex. Purpose 1 and Purpose 2 are now being deemed as the scientific breakthrough of the year. What's interesting about Purpose 1, which was focused on cisgender women, it was focused on adolescent girls and young women. So the age cap there was somewhere between 15 and 35, which did not include people who were older and younger. And in terms of Purpose 2, that median age, which was inclusive of the transgender women and men, the median age was 29, which means there were also fewer people who were over 50 included in that study. Where our opportunities lie right now, especially for women in the United States, is in the current study that's enrolling HPTN, HIV Prevention Trials Network 102, which is also known as Purpose 3, which is an open label study that's now focusing on cisgender women in the United States in terms of real world access and of uptake and persistence on and looking at comparing lenacapavir with, or the twice a month injection, subcutaneous injection with FTAF or Descovy, which was a study that where women were excluded from when Descovy was initially approved in 2019. So in this study, what's important to know is that there is no age cap. They're only enrolling 250 women. They're less than halfway there, which means we have a greater opportunity for all of these sites to now look to ensure that older women are being recruited and retained into these studies over the next few years. So going forward, it's going to be important for us to shift the center. Because you know what if you know me, you know I always say that if you fix it for Black women, especially those who are moms, grandmoms, aunties, sisters, nurturers, caregivers in their blood and extended families, when you fix it for Black women, you fix it for everyone across all the ages. If we remind ourselves about the PrEP to need ratio, which essentially looks at the numbers of HIV incidents compared against the numbers of people who would benefit from PrEP, the lower that score, the higher the need. We have to do something different to move the needle on that disparity. Centering Blackness, centering Black women, centering Southern Black women, centering Southern Black older women, and centering Black older women who are Southern and poor are critical to us understanding these issues. The last couple of things I would say is that if we think creatively, beyond what we know now, having a collaborative community-based sexual health and sexuality initiative and intervention is critical so that we can include family level, community level conversations for people who are not getting appropriate sexual health education early on or later. We have to eliminate the missed opportunities like emergency departments and urgent care where older people are presenting. When I present for mammograms, when I present for menopause therapy, that all of these different places, including therapy for mental health, are where we can also engage folks around understanding their vulnerabilities to HIV. And technology is going to be our newest friend in one way or another through telehealth or through AI practices that allow us to build digital communities of information, of resources, and also of practice to make sure that older women are included. I'll close with that because there are a whole lot of other places that we could go. The one thing that I would offer up is that diversity meaning diversification of all the things, the providers, the options that we have for prevention, diversification of locations and where access to the services are, and recognizing that treatment is prevention in the clinical context of it, but in the real world context of it, treatment is not equaling prevention in a couple of ways. And I know I'm over time, Russell, but I definitely wanted to share this critical point because this is where the nexus of being able to equalize how we're able to use the care continuum for U equals U and how we're using the prevention continuum for PrEP are not equal. U equals U gives us an explicit impetus because of an HIV diagnosis. It gives us accessible information because of our engagement in our healthcare around our HIV status. It has a whole system of shared decision-making that comes along with treatment and care. There's a community of practice. There are support systems. There's a whole body of resource for people living with HIV to connect with each other. There's a language connection to undetectable equals untransmittable that does not exist in pre-exposure prophylaxis. And there are tangible measures, my viral loads, my CD4 counts, viral suppression. It's real to remain negative, but it can't touch it. And there's a static endpoint, which of course is not only viral suppression, but quality of life. And with prevention, there's a dynamic endpoint. So it's not actually equal. And not only is it not equal, it is yet not equitable. And so I leave you all with these really important considerations for where change needs to happen to make sure that older women who are more vulnerable to HIV are as included as all of the other populations for whom providers have told us they think are more appropriate. Thank you.
Thank you, Dazan. Amazing. Thank you so much. All right. We're a little over time, but I want to jump into, I think we have time for those of you who are able to stay to get to some of the questions that were posted in the chat. So the first, and this came, I think, Jeffrey, during part of your presentation, and anyone can respond to it, but the question is from Maud, how difficult or easy is it for a service provider to ask for an HIV test when a patient visits for other services?
It's very easy. Simply, well, at least for me in my practice, right? I just put the order in our electronic medical record system. I associate it with a code, which is screening for HIV, and that's it. Usually not an issue.
Okay, so according to you, shouldn't be that complicated. All right. And Rafi, this is for you. This is a comment, and I don't know if you want to respond to it. Maud said, thank you for your presentation, but the feeling is that the rates of STIs was so alarming in HPTN 083. As an advocate, I think we have neglected STIs and concentrated more on HIV, just like what we used to do with concentration on pregnancy prevention and not mentioning HIV in adolescents. I don't know if you wanted to respond to that at all.
Yeah, thanks, Russell, and thanks, Maud, for that observation. I agree that the rates of STIs that we're seeing in all of these HIV prevention trials are unacceptable. And I guess I would, I hope you're okay with this. I'm going to turn it around to you all and say, what we need to do in response to that is to continue to advocate for resources to find additional STI prevention interventions, right? Because you could very easily just say, well, condoms, right? And completely agree. And we can't forget condoms. But the truth of the matter is, if people could, would, and will use condoms, we wouldn't have these problems. So there's an acceptability, a feasibility of consistent use that, whether or not we completely understand it, is the reality. So we need to continue to push and look for interventions that have activity against both HIV and STIs for all populations.
Thank you. And here's a question I think is for all the panelists. So what are some ways to conduct outreach targeted to older populations as far as HIV testing and prevention goes? What environments or settings would be most effective for this? And this is from Casey.
So I responded in there just in the interest of time. I I've thought about this a lot as we're thinking about, removing the upper age limit of the HIV testing guidelines. How do we implement that? It's not just in a clinical setting. So, folks are interested and you have an HIV testing program, reach out to nursing homes, reach out to assisted living homes, reach out to your senior citizen centers that always have health education and program needs, and they're always looking for things to do. You can also, in the United States, you can also reach out to your area office on aging, which is called a AAA, to ask about collaborating around HIV testing, because they may be part of having a health fair or health program or some kind of education program or conference for older folks. And senior high-rise buildings are also another outreach opportunity. I remember very clearly in the 90s in Atlanta, Georgia, going to a high-rise building in Midtown Atlanta and having an older person living with HIV go with me to tell their story. And we talked about HIV and HIV testing. This was pre-PrEP, so we talked a lot about condoms and needle exchange programs. So there's so many opportunities to connect with folks, especially if programs are funded by the Older Americans Act, really kind of figuring out where those programs happen in your local community. So there's lots of opportunities. I mean, folks love to have health fairs for older folks. So, get your cholesterol check and heart check and all that stuff. So HIV testing should be offered, and, having conversations around sexual health and PEP and PrEP and harm reduction is going to be a really important part of those health fairs that you don't traditionally see, but we should start changing the culture around that.
And
Thank you.
if I add to it, I think there's two, I absolutely concur, and that's a lot of the places where we do. We also use our mobile clinic in those settings as well. But there's also a lot of advantage to work in partnership with those faith institutions that are friendly and welcoming. They have a robust amount of senior programs, senior support systems, and also we're recently involving faith health workers. So those community health workers who come out of the churches and out of the mosques are being trained in how to educate and work with seniors around HIV and their sexual health. And I haven't, because that's just not me, but I got plenty of people among my own peers who are dating online. And so if we're not sliding into some of those sites where they're meeting each other, where they're connecting, where they're finding out their information, this too is, technology is not just for the younger generations. We're engaged, we're involved, and we're hooking up through it. So I think that those are also spaces that need to be accessed by us and accessible to us as well.
Thank you. Thank you. And Days I'm where you need to go. And I have one question for all the panelists. It's a two-part question. And I'll just lead off by saying that I'm thinking about, Jeffrey, the slide that you presented, indicating, the age group. And I think about, we're talking about older adults, and like 50 is somehow this magic number, but, depending on who you are, 45 and up, like if you were to add that number into it would be even more alarming. So given that, what are some, and this is for all of you, what are some barriers to engage and or recruit older adults in clinical trials and or HIV prevention? And then the second part of that is, how do we address those barriers?
Can I start with that? Because I do have to
go for it
out really quickly. And
we'll start with you, Days, and
for...
then we'll just do a loop. Thank you.
Yeah, so first and foremost, I think that we have to understand that HIV prevention clinical trials, that first of all, we have to shift how they get done, because especially for women, they're not conducted in the United States. And so that's first and foremost the issue and a challenge that has to be overcome in terms of the research design and the studies that are meaningful and that are powered appropriately, that can be generalized, but that can also include people in the United States. So that's the first and foremost. But so that's one of the biggest barriers, is that we can't even get those studies when we're talking about especially cisgender women in the United States. The second, I think, biggest barrier to that is siloing the HIV research that we do. You just mentioned it in some degrees. I think that it has to be concomitant with other conditions that folks are dealing with, even if it's specifically with their sexual and reproductive health. Maybe I would more likely voluntarily get into a study that's around hormonal diminishment, that's around menopause, that's around breast cancer, that's around cervical cancer or HPV, because I wasn't in the age group to get the vaccine, right? And so if we can look at how to broaden sexual health in the different clinical trials that we're doing for prevention, maybe we don't continue to silo HIV from STIs. Maybe we don't continue in a prevention space particularly to continue to separate HIV as a chronic condition from other chronic conditions. Are we studying HIV risk in people who are diabetic? Are we studying HIV risk in people who have hypertension and heart disease? That's probably a more likely avenue to get people in than simply going after the HIV/AIDS piece, because as it's been put in the chat, stigma is still a big issue, but also the lack of information and the lack of awareness of the role that HIV plays in older people's sexual health and sexual lives are critical. So I really think it's important to de-silo it and connect it to something that is meaningful in their other health experiences and realities.
Thank you, Daison. Jeffrey, any thoughts?
Yeah, sure. Really quickly, I mean, I think I agree with Daison's comment, and it sort of tag teams on what I was going to say too, which was just in terms of when we think about recruitment and we think about getting study participants into trials, right? We have to think about doing concentrated or targeted efforts at recruiting in locations where older adults would be more likely to pay attention to research trials or think about participating in something along those lines. And then also just in terms of when we think about inclusion and exclusion criteria, you know, I think one of the issues where we get into the it gets challenging is in people with multiple comorbidities and multiple other issues where, I know in the context of clinical trials, we want to get the quote unquote cleanest data possible. But I think it is important to also consider situations where people have other comorbidities or other medications that may be important to take into consideration, because we're talking about real world situations or scenarios. And I think investigators need to sort of be aware of that in their planning.
Thank you. Terry, and then Rafi will have you take us home.
Yeah, I mean, the three things that I've thought about off the top of my head is older people need to be on the community advisory board. That's part of the clinical trial design and efforts. I think often they're not invited, or, people aren't really thinking about that. I think this is an opportunity to collaborate with gerontologists and geriatricians to make sure flyers are, in the waiting rooms or that are being distributed or, or posted up in the clinic space, so that there is a reminder to say, hey, do you know about this clinical trial? And then I think the other thing, Daison put in the chat, AARP. Well, AARP, which is, always sending us membership reminders on our 45th birthday. They have magazines and they have a website, and older people get these magazines and get these emails from them, collaborating with them to maybe do an article about this upcoming clinical trial that people can participate in and why it's important to, participate in things that can further our knowledge around sexual health and HIV prevention, I think would be key.
Thank you. Rafi.
Thanks. I agree completely with everything that Daison, Jeffrey, and Terry said. The one other thing I just would observe is, we have, unfortunately, in this country, direct to consumer marketing, right? Every commercial on television, every other one, even on the streaming services, right, is for something else, a mab, right? And and if you look at who's in these trials, particularly around HIV and HIV prevention, nobody ever shows somebody from one of these older age groups or appears to be a member of an older age group. And, unfortunately, marketing is everything. So I think the perception, and again, we have a long way to go to learn how to do public health promotional education, right? I mean, Apple has figured out, right, how to make all of us absolutely need, the next iPhone whenever it comes out. but we have not done a great job at making people need HIV and STI prevention. And until we figure that out, we're going to be behind the 8 ball. But particularly around older individuals, right? Older individuals watch TV. Where is the "this is for me" in that space? So I think in addition to all the really spot on observations others have already made, I think that's something else that we need advocacy around and we need knowledge around, because as physicians, as advocates, as consumers, we're not good at that. We're not trained to do that, but there certainly are people who are good at it. Where are they at this table?
Thank you for that, Rafi. And I didn't even prompt you for this, but this group, this working group has been working on developing a campaign specifically around sexual health and HIV prevention for older adults. So can't wait to share that with you all. So you must have been reading our minds.
I would love to see that. I mean, I think that's the most exciting thing I've heard like in weeks.
Yeah. So that will be coming soon. We're just testing it out to see, get some responses. So thank you all so much for taking the time to present. I know that this is a busy time of the year, so thank you so much. And thank you all for taking time to join this conversation. And as I noted at the start, this is just the first webinar of a 3-part series, so stay tuned. And we hope that you will join us for the other webinars as we continue this discussion. So take care, everyone. If you celebrate the holidays, happy and safe holiday, and we will be speaking soon. Thank you.